These are my disclosures. Two birds from Busan, and I'll be talking about chronic hepatitis C. My talk will be much simpler than what Professor Loccanini has been talking about because we have found a cure for hepatitis C. I'll start with some epidemiology of hepatitis C, especially in the Asian Pacific area, and then I'll discuss about when and who to treat, and then I'll spend some time on the direct-acting antiviral, and finally, actually, just one slide, actually, on a special population on the treatment of renal failure patients. I will not touch upon the co-infection because it will be spoken upon by the next speaker. So what about the epidemiology of Xcv? According to the WHO this year, there is estimated to be 130 to 150 million people with chronic hepatitis C in the world. And the annual mortality rate is 500,000, which is around half of that due to hepatitis B. I'll mainly focus on the epidemiology of Xcv in the Asian Pacific region, in the Asia, Australia, and also including Egypt, which is not obviously not in Asia. It actually contains the largest population of Xcv infected persons. Something like 49 to 64 million adults are infected with hepatitis C. And China alone actually has more hepatitis C infected persons than all of Europe and America, mainly because of our huge population. The high prevalence areas in Asia and Africa, especially in Egypt, Vietnam, and also Pakistan and Taiwan. And there's evidence that the prevalence increases across the age. And here you can see in all the areas, actually, the older the subjects are, the more likely to have hepatitis C. And this is not surprising because you have to have the time to acquire hepatitis C, mainly through IV use or actually transfusion before the days of screening for hepatitis C in the transfusion services. And this actually brings me to a very important point that one should definitely try more effort in the primary prevention of hepatitis C and also enforce early diagnosis of XCC by screening and also enforce alcohol cessation for the hepatitis C subjects. And one should like to change the treatment strategy for the infected carriers. And I'll come back to this later. And to me, this last point is obviously very important since we've actually got cure for hepatitis C. And here, this map shows the high prevalence area of Asia-Pacific region. The red area is the one which has got the highest. Vietnam tops the list, not counting Egypt. Vietnam, and then followed by Pakistan and also Taiwan and mainland China. Cambodia, Thailand, Indonesia, and Korea, and Laos are in the intermediate area. And Myanmar, India, Japan, Singapore, Philippines, and fortunately Hong Kong is in the relatively low incidence area. And here you see there's really a lot of diversity, genotype diversity in the Asian Pacific area. Genotype 1 actually is everywhere, but Australia, China, Taiwan, and North Asia actually got the highest population. Genotype 2 mainly in Japan and also Korea and Taiwan, not very much in Hong Kong. And then genotype 3, India and Pakistan. Genotype 4, Middle Eastern areas. Genotype 5, fortunately, is quite rare in Asia, except for a small number of infected people in Syria. And then genotype 6, of special interest to me, actually, is Vietnam and also in Southeast Asia and obviously Hong Kong. Just a brief word about China. As I've mentioned, China has got more people in total suffering from hepatitis C compared with the whole of Europe and America, something around 13 million, even though the incidence itself is not exactly huge. And the main distribution is actually genotype 1, followed by genotype 2, but actually genotype 3 is also really quite common in China, 13%. I must stress that there are certain limitations to epidemiological data because a lot of these reporting of new infection rates depends on the size of the population. A big country like China and Asia, it is not really that easy to document new incidences. And then there's considerable variability in the type and quality of the prevalence studies. In Australia, Egypt, and also Taiwan, for example, there may be large population studies, but in India and in China, it's actually subgroup studies. And also there may be overrepresentation of men in studies from Egypt, Arabia, and also Pakistan, mainly for the males. The females, the statistics are actually not so prominent. And I would definitely like to have actually accurate data from these countries because it's essential for us to prevent the infection, which is definitely preventable. Just to show the wide variability of the prevalence risk factor, in Egypt, for example, I'm sure you all know, it's mainly because of the use of IV injections for the treatment of schistosomiasis back in the 1960s and 70s. And subsequently, there is actually, I've just recently talked to an Egyptian hepatologist. He says that they are still reusing of needles. In Pakistan, public shaving of beards and, I don't know, other body hair, and then tattooing, also sexually transmitted HCV, and also acupuncture can still transmit infection. But in China and Hong Kong, actually, as far as I'm aware, acupuncture nowadays, they use disposable needles. In Japan, and I was told this also by Professor Kuda before he actually died, that it's mainly by transfusion. For the patients after the Second World War, actually, there was a large population with TB infection. And these patients very often got transfusion before the screening for Xcv was available. In Australia, it's mainly IV drug use. And for Hong Kong, actually, fortunately, as I've mentioned, we've actually got a pretty low incidence. These are the figures from the blood transfusion services, and roughly 50% of our patients obtained the infection by blood transfusion before the screening of Xcv on July the 1st, 1991 by the Red Cross in Hong Kong, and the 25% would be due to IV drug use. Nowadays, obviously, the main new population would be through IV drug use. So I'll give some slight emphasis on genotype 6. This, incidentally, is a tea plantation in Malaysia. And it was actually, the reason why I'm interested in it, because it was first identified actually with a cooperative study from Hong Kong and also transfusion services in Scotland. We actually studied 212 Xcv blood donors from Hong Kong. Genotype 1b was the predominant type. However, the next one was actually genotype 6a, 27%. And genotype 6a is actually can be as high as 50% in certain regions of Southeast Asia. And it's also more common for IV drug use and also thalassemia major patients receiving transfusion. And it's unique in the various genotypes because it's got a huge diversity, at least 22 recognized subtypes from 6A to V. Actually, they may run out of alphabets quite soon. And then with the older innogenetic LIBOR study, it may not be identified. So you have to use a new technique, new assay, or use sequencing assay, because otherwise it may be mistaken as genotype 1. And here you see the diversity of the genotype 6, and it overlaps with genotype 1, 4, 3, 2, etc. And as I've mentioned, it can be really very high. In Hong Kong, 30%. In Vietnam, 36%. In Thailand, 18%. And in Burma or Myanmar, 49%. And in Korea, fortunately, 1.4%. And here, this is a study from Ho Chi Minh City of 842 patients. And as you can see, actually, genotype 1A and 1B made together 30% of subjects, but genotype 6A and 6E, a total of 54.4%. So genotype 6 is actually of definite local significance. So to summarize the epidemiology, in the Asian Pacific region, there's a broad representation of most of the genotypes, maybe except for genotype 5. And then I think urgently needed would be education to prevent the spread in those at risk, and also effective screening to accurately diagnose the people who are affected. But also, to me, most importantly, is to access simple and effective pan-genotypic treatment. And this is unfortunately because of the price, cost of the drugs that are available, not really so easily solvable. So I'll come to the Xcv treatment. This is back in 2011. There are 4 potential sites, but I'm sure all of you know that nowadays we are only concentrating on Xcv replication in the 10 viral proteins. And here you see the viral proteins, and the important ones actually, and these are actually almost sufficient. The protease inhibitor in NS3 and NS4A, and I've given some examples here. I will not talk about simapravir or isanaprevir. And then NS5B inhibitors and NS5A inhibitors, and these are all actually very potent. And, okay, not yet. This is my rainbow arrow for the treatment of hepatitis C. In 1986, it is 6% SVR, sustained virologic response, and within 30 years, it has jumped to 99 to 100%. And later this year, I hope there will be marketing of licensing of a pan-genotypic drug. So who to treat and with what drugs? This actually was my cruise ship during the Christmas season. The AASLD and the EASL guidelines says that the goal is to reduce all-cause mortality, including end-stage end-stage disease and XCC through cure, as evidenced by SVR. And we actually do have evidence that this can be achieved. It's proven to be effective in a meta-analysis of 6 studies. This was in 2015, but most of the studies were only using interferon. And therefore, you see of the 443 patients, only 137 actually achieved sustained virologic response. Nowadays, it will be nearer 443, actually. But even with those, the limited number of 30+% SVR, 53% actually showed cirrhosis regression with a risk of regression compared to those who did not achieve sustained virologic response as 2.69. And another study showed that late relapse rate in the sustained SVR patients was actually only very low, 1 to 2%. And SVR actually is associated with reduction in XCC and liver-related mortality. And here are the relative risk ratio in the brackets. So who to treat? Very easy. All patients should be treated. Anyone with chronic hepatitis C now should be treated, except for those with short life expectancy due to other diseases. And for those patients with life expectancy related to hepatitis C, you can still treat them, either before or maybe after liver transplantation. This is for individual consideration. And one should also apply some pre-treatment assessment, mainly to assess the fibrosis, either by mostly actually nowadays by non-invasive methods like FibroScan or APRI. One can also do liver biopsies, but it is obviously more risky than FibroScan and using the APRI. The reason why we would like to stage the disease is so that we can screen, see whether the patient requires longer treatment, and also one would like to screen for XCC if the patient already has significant fibrosis. I'll only mention, in order to make the discussion more controllable, I'm only going to discuss 3 recommended licensing agents, and these are all actually recommended by the AASLD and EASL guidelines. First is Harvoni, which is a combination, one single tablet combination of Ledisavir, which is an NS5A drug, plus sofosbuvir NS5B drug. And this was licensed by FDA in October 2014. And the next drug is Vicuripac, which is contain the protease inhibitor. This, however, has to be enhanced by ritonavir, a P450 inhibitor, and also an NS5B A inhibitor and also an NS5B inhibitor. This was actually licensed 2 months after Harvoni, but because of the use of ritonavir, before, if the patient should be on any other drugs, one should check this particular website before using the drug to see whether there is any need for dose reduction. The third drug that I would like to actually mention is only licensed earlier this year, Sepetier, which consists of a protease inhibitor and also NS5A inhibitor, and this was licensed in January this year. And if one wants to use this particular drug, one would like to test for resistance-associated variants before treatment, because you may have to give a slightly longer period of treatment for patients with RAV. So the recommended treatment for genotypes 1A and B, to sum up, you can give Harvoni for 12 weeks. Vicariapac, incidentally, this is not a spelling. The drug company likes it to be in small letters, not capital letters. Anyway, Vicariapac should be given in 12 weeks again, and then Sepetier, 12 weeks if there are no RAVs before treatment, and if there are RAVs detected, then 16 weeks. This is all very simple. And then recommended treatment for genotype 4, all three combinations, all just for 12 weeks. Recommended treatment for genotype 2, sofosbuvir plus valgarorin, which has some side effects, valgarorin, obviously. 12 weeks, or dactacavir plus sofosbuvir for 12 weeks. And then for genotype 3, dactacavir plus sofosbuvir or sofosbuvir plus valgarorin plus, nowadays really no one really wants to use it, pegylated interferon for 12 weeks. And then for genotype 5 and 6, Harvoni, again for 12 weeks only. With this, actually, I would like to go on to the next section, which is on an as yet unlicensed pan-genotypic drug, which I hope will be licensed late next month by the FDA. And this is actually sofosbuvir plus valpetasvir. Sofosbuvir, as we mentioned, is an NS5B inhibitor. Valpetasvir is actually a pan-genotypic NS5A inhibitor, and the two of them would be combined in a single drug again. And here you see the profile of valpetasvir, which is an NS5A inhibitor, which is pan-genotypic. And it's also, you can see the EC50 value for all the genotypes, even for genotype 3, which is supposed to be the difficult type to treat, is still very potent. And there's also a very high barrier to resistance, as shown in this particular slide, except for Y53H. Otherwise, nearly all the RAVs are actually sensitive to this particular drug. And also, not only for the NS5A, it is also actually active against the RAVs for other NS5B and also protease inhibitor variants, resistant variants. And so, just a few words about the Astral Studies. The first one was actually the study for genotypes 1, 2, 4, 5, and 6, published in November last year in New England Journal of Medicine, simultaneously together, actually at the same time, right at the same time, when this was actually presented in AASLD in November. And the study is very simple, just placebo patients versus sofosbuvir plus valpetasvir in the 5-to-1 randomization. Only genotype 5 patients did not actually receive this randomization because there were too few patients. All the patients were actually treated. And here you see the demographics. Quite a few of them actually has got, the median BMI is definitely obese by the Asian standards. And I thankfully have not seen a patient with a BMI of 57 in Hong Kong, not yet. And around 18 to 90% of patients has actually got cirrhosis of the liver, and quite a few of them were actually treatment experienced. The median log was actually quite high, and here you see the genotypic representation. Genotype 1 obviously the largest, but they have actually also got 35 patients with genotype 5 and also 49 patients with genotype 6. And here you see the overall results, 99% SVR12. And here you see the spread from genotype 1, 2, 4, 5, and 6. And they are so proud as to show you, actually there are only 2 relapses. one patient died, 2 patients lost to follow-up, but only 2 relapses, one for genotype 1A and 1B. And for patients with or without cirrhosis, for patients with or without pre-treatment, is still the same, 99% SVR. And also for patients with resistance-associated variants, 99% was still sensitive to this particular combination of drugs. And as for safety, it only shows, this slide is only to show you how safe it is. Actually, there was one death, but this patient actually died 8 days after completing treatment in the sleep, obviously presumably not due to the drug. So the conclusion from Astral 1 is actually 12 weeks for genotype 1, 2, 4, 5, 6, SCR 99%, and it's really very safe. And then the Astral 3 study, mainly for studying genotypes 2 and 3, this time actually, because 3 is one of the most difficult genotype to treat, so they give this combination soft plus valpropatisvir for 12 weeks or sofosbuvir plus ribavirin for 24 weeks, randomized in a 1-to-1 ratio. And the combination of sofosbuvir plus valpropatisvir, 95% SVR compared to only 80% with a longer treatment with ribavirin. And again, this actually applies for patients with or without cirrhosis, 91 to 97%, and also with previous treatment or no treatment. And once again, actually, 88% of the subjects with resistance-associated variants were still sensitive to the drug. So 12 weeks for genotype 3, it is superior to 24 weeks of sofosbuvir plus ribavirin, and is actually well tolerated. And here are the pooled data for genotype 1, 2, 3, 4, 5, 6. And the total number for the whole population, 98% I think achieving SVR, but even for the difficult to treat genotype, 95%. And just one final study on the Astral 4, which is for the decompensated liver disease. Sofosbuvir plus valpropatisvir for 12 weeks, or plus ribavirin for 12 weeks, or just this single tablet for 24 weeks. And here you see actually for all, for the overall or genotype 1, genotype 3, and genotype 2, 4, and 6, combination of ribavirin is actually better. So for patients with decompensated liver cirrhosis, sofosbuvir plus valpropatisvir plus ribavirin would be better than just using the single tablet. And just to prove that actually, once again, with SVR, you can actually reverse cirrhosis. Here you see the subjects with MEL score, baseline MEL score of lower than 15, 52% of them show improvement. Okay, 27% show worsening, but it's only a mild worsening. For patients with MEL score of more than 15, 84% actually show improvement, and only 8% show worsening. And these are obviously the subjects who may require transplant, but there is actually reversal, potential reversal of a worsening liver disease. So, as I've promised, only one slide on the special population. For patients with creatinine clearance of 30 to 80 mils per minute, no dose adjustment with the drugs that I've mentioned. And for patients with creatinine clearance level of lower than 30 mils per minute, you can, for genotypes 1A, 1B, and 4, you can use FRACP for 12 weeks or sapazivir for 12 weeks. And in conclusion, very short actually, I think a substantial proportion of the world's Xcv population resides in Asia. And I think public education is definitely actually urgently required. But even more urgently, actually, is the greater availability of the direct antiviral treatment. But they are very, very expensive. And not many governments, including Hong Kong, can give it to the patients free. But there's still hope there, because the cure rate is something like 95 to 100%. Improved from 6% in 3 decades to 95 to 100%, and then a lot of them only require treatment for 12, maybe 16 weeks, and pan-genotypic DAAs would soon be available, hopefully by the end of next month. So thank you.